expert in the sleep science. We look forward to engaging in today's intellectually stimulating lectures. As today marks the end of this 5-day program, I request you all to make the most of it and gain maximum benefit. Let's begin with our first session of the day, which explores sleep bruxism, a condition often overlooked yet significantly impactful. We invite Dr. Christina French, ma'am, for this session.
Oh, perfect. I think I'm going to take these two. Yeah, I think so. That's better. Okay, I can handle it. We have. Hi. Okay. Good morning, everyone. I'm going to be seated today because I'm also tired, just like you are. Last day of the course, lots of new things going through the mind. So, we are talking today about sleep bruxism, then narcolepsy, and then circadian rhythm sleep disorders. To start, sleep bruxism, we have the concept. Sleep bruxism is a repetitive jaw muscle activity characterized by clenching or grinding of the teeth and or by bracing or thrusting of the mandible during sleep. So it's called a movement disorder of sleep. Here we have a video that I want you to see. We are not listening to anything, but just have a look at how this guy thrusts his mandible. Can you see that? He makes some movements and then he wakes up, turns to the side, and continues make it. And then he wakes again, try to turn to the other side. So as you can see, the events of the sleep movement disorder called bruxism, sleep bruxism, are happening throughout the night. Thank you very much. And the events are making, he's just a report that he's saying how tired he was on the next day. So the movements, the biggest thing is that it fragments sleep. The person wakes up a lot during the whole night. So one of the main features, one of the main characteristics of sleep bruxism is sleep fragmentation, okay? This is a disorder that we treat together with the dentists. This is a movement disorder that can occur both during sleep, then it's called sleep bruxism, and can also occur during awake, then it's called awake bruxism. They are almost the same thing, but are different entities and treated almost in the same manner. But sleep bruxism is a very common condition. About 80% of adults grind their teeth during night. So we are going to go deep into those things here. It can be primary, someone can just have it, or it can be secondary to another condition or using of drugs, for example, or medications. I have some patients going on lithium for psychiatric disorders, and they start to have complaints of sleep bruxism. It is often associated with anxiety and hyperactivity. So anxiety is something that we must pay attention in our patients, because sometimes we need to treat this anxiety, need to refer the patient for psychology or psychiatry before start treating the sleep bruxism. Some possible mechanisms that this sleep bruxism may occur. Just let me get the pointer. Yeah. Some possible mechanisms that can lead to sleep arousal is this autonomic and motor dysfunction. So we will have interaction with sleep and vigilance network. We can also have some influence of the circadian and ultradian rhythms. So the feeding cues might be not properly given, and then these could lead to anxiety, stress, and other things that in turn could lead to sleep bruxism. We can also have some deficiency or differences in neurotransmitting. Genetics always plays a role, but I think one of the most important things in sleep bruxism is the personality, anxiety, and maladaptive coping. So, sleep bruxism can lead to abnormal wear of the teeth, as you can see in this image here. And it can lead to pain in the teeth, in the jaw, in the temporomandibular joint. Can lead to headache, tooth sensitivity, and sleep is disturbed, both for the patient and for the bed partner. So when we have a patient and we look into his mouth, we can see if there are any possible signs that you could suspect of sleep bruxism. And in case of yes, you just send to a dentist. Well, I think this is another profession that is growing a lot, just like physiotherapists. They are the sleep dentists. Okay, so if you have friends that are dentists, you can tell him about sleep and say, oh, there is a new area that you can go through. You can treat sleep bruxism. You can treat sleep apnea. I think those two areas are going to grow a lot as we gain knowledge about sleep science, okay? So here we see some clinical features like masseter hypertrophy. You see, I have a little bit here. And we can see here in this gentleman, in this lady, here also. So masseter hypertrophy is something that may be present. It's not in every patient that you are going to see this. Of course, we have all those intraoral findings that you can see. You see states of erosion in the teeth. You see that there are some states that the clenching is going on here. We can see some wear, like mild ones or moderate or even severe ones that the gums are exposed. So these things we have to look for. There are also fractured tooth, cracked ones. Patients can fracture the root and things like that. So we just ask for how is your dental condition? How long you've been to the dentist? Okay. And then we come to something that we physiotherapists are very used to treat, that is pain and range of motion. Some findings of sleep bruxism can be pain, limitation of function, reduced range of motion. So patients will complain about pain when sleeping, when chewing something, even when chewing hard things like meat, okay? They say, oh, I can't go out to a barbecue with my friends because every time I go, I had lots of pain. They also have discomfort, fatigue, tension, difficulty with the jaw movements or maybe with the neck movements when waking up. And then can wake up with pain, with lots of tension, sensitivity, tooth sensitivity, and also may present headache. The impact of sleep bruxism on sleep architecture is that we have fragmented sleep, an increased time for sleep latency, so it takes longer to go to sleep, increased time of N1 sleep stage, might present nocturnal myoclonus, and we have this alpha wave intrusion into delta sleep that I'm going to show you a picture so you have that in mind. We have these abnormalities that are compatible with increased anxiety and depression, and shortened sleep, slow wave sleeps, the deep sleep, okay, N3 sleep stage, deep sleep. So here you see an example from the work from the group of the Dr. Gilles Lavin in Canada. What we see here is that these black arrows show us that these are N3 stage, so deep sleep, slow wave sleep. And in between those slow wave sleep, we have these little ones here that are the alpha sleep. So we call that alpha wave intrusion into delta waves. This is a very common characteristic of pain patients. And it's very common to find in the PSG. This one here, just a curiosity, but this one here was the alpha into theta waves was discovered by Moldovsky about 50 years ago in fibromyalgia patients. Fibromyalgia was at the beginning it was called a sleep disorder, okay, because of this very, very intrinsic relationship with sleep. It's not any longer. So how can we diagnose sleep bruxism? We, as a physiotherapist, we cannot. But the dentist will ask, if the dentist will have a patient with a possible diagnosis, a suspicion, he will conduct an anamnesis and see if there is a report of teeth gritting by the patient or by the bed partner or by someone in the family. And we'll see if the patient reports jaw muscle tightness or other pain or discomfort. And the gold standard, again, for the diagnosis of sleep bruxism is a polysomnography, as we have seen. It might be associated to audio and video recordings to record the masticatory movements or the contraction of these movements, of these muscles, that can be evaluated. So in I think November, December of 2023, the International Classification of Sleep Disorders launched a text revised edition in which the criteria for sleep bruxism was the presence of repetitive jaw muscle activity characterized by grinding or clenching of the teeth during sleep, and the presence of abnormal tooth wear and transient morning jaw muscle pain or fatigue or temporal headache will be consistent to the reports of tooth grinding during sleep. So dentists will use now these criteria to diagnose sleep bruxism along with the PSG. Here we have, remember that I told you in the PSG lecture about the sleep bruxism montage, the way the electrodes are placed. So you see a lot of electrodes going on the face and all the muscles from this patient. So this is how it looks like, the sleep bruxism montage for the polysomnography. And here we also have an obstructive sleep apnea, desaturation, and the lack of a little bit of the effort in the belt. But what we see here is the right electrodes showing these phasic movements, and here the left electrodes. So we have this pattern, this repetitive pattern going on. And while these muscles should be relaxed, they are in an involuntary manner working. Sleep bruxism is another of the sleep disorders that we don't completely understand what's going on. So there are some evidence talking about the possible consequences that exists for sleep bruxism. One of them is this sympathetic activation. So we will have a rise in the sympathetic cardiac activity occurring between 4 to 8 minutes before this rhythmic masticatory muscle activity. And then we will have an increase in the EEG frequency 4 seconds before that happens. 1 second prior to the rhythmic masticatory muscle activity, we will have tachycardia. And then we will have almost at the same time, the suprahyoid muscle activity will increase. And in some individuals, a big breath could also be noted. So this rhythmic masticatory muscle activity occurs in the masseter, resulting in tooth grinding. So this consequence does not occur in all these movements, but it's primarily associated with young subjects, young and healthy subjects. So as we can see, we have an autonomic cardiac activation occurring in sleep bruxism. The symptoms that we have are the squeaking, clenching that may produce some noise, teeth clenched when waking up, this feeling of tension and feeling of stiffness, waking up with restricted movement, discomfort in TM joint muscles, difficulty in opening the mouth, complaints of temporomandibular joint and cervical pain, neck pain, morning tension, hypertrophy of the masseter in some patients. In some cases, we can also have change in the symmetry of the face because one side can be stronger than the other. These blue ones here are the symptoms that physiotherapists can treat. And these three here are the symptoms that the dentists can also treat. So excessive tooth wear, injury to the edge of the tongue or inside the cheeks or even the tooth itself and the sensitivity in the teeth and or in the gums. And how is sleep bruxism how frequent it is with other comorbidities? it will be but it will be easier if we could treat just one disorder. But what happens most of the time at the patients presents disorders along with other sleep disorder and with a medical comorbidity. So that is really a challenge for us to treat. Sleep bruxism is very, very common with obstructive sleep apnea and with insomnia. So these three disorders, they can be presented together in different manners. Bruxism and obstructive sleep apnea, bruxism and insomnia, okay? All the three of them together. But we know that all of them lead to arousals. So this is one of the main things, the main features that we need to address. And this will, of course, lead to a complaint of poor sleep quality in most of the time and fragmented sleep. So we have this evaluation map that we made in the Brazilian Sleep Consensus, trying to make it simple. So we would start with the anamnesis of the patient, asking these questions. So, do you grind your teeth? Has anyone ever heard you grinding your teeth? Do you feel teeth, any gum pain or aching when you wake up? So you ask a lot of questions to the patients. If they say yes, you refer to the dentist for diagnosis. But if you see that they also have complaints of fatigue, drowsiness, unrefreshing sleep, reflux, and if you see that you're talking to the patient is biting the nail, clenching a pen, a pencil, or something, or is making some strange movements all the time, then you see that this patient may have parafunctional habits that you must address. If you note stress and psychological conditions, or the patient says he went through previous psychotherapeutic treatment, you might consider refer this patient to psychology. And then you have the clinical evaluation, where you will see the masticatory musculature, the neck and thoracic spine, and the upper limbs. So exactly the same idea that when we treat patients with pain, we can have these drawings here where the patient will draw where they feel the pain. And you have something to compare between before and after treatment. So this material is on the reading materials that you will all get at the end of the course, okay? So I strongly encourage you all to have a look at that, especially for those who want to work with sleep bruxism. After having the physiotherapeutic assessment per se, you can see if the symptoms are absent or present, and then proceed to treatment. The treatment can be arranged in various manners. We are going to go through that right now. So we can have relaxing exercises, some forms of currents like TENS or microcurrents. We can have dry needling, acupuncture, nasotherapy, myofascial therapy, okay, massage. There are no validated questionnaires for sleep, okay? So I added this here because I know you've already had a lecture with Professor Zubia about the sleep questionnaires, but there are no questionnaires specific for sleep bruxism. But there is this STAB, that's a standardized tool for the assessment of the bruxism. This is being working by this group of Canadians. They are a very strong group in researching about sleep bruxism. And this consists mainly of two axes: the evaluation of the evaluation and the consequence of the sleep bruxism for the patients. So it's a very long questionnaire with 66 questions. So it's something that I can't perform in my daily practice. It's something related more to research. And it's kind of a new thing. So we are starting to use that in research. What about the treatment? The treatment, it mainly consists of a combination of what we call the 5 P's. The first P stands for oral appliance or occlusal plate that will make the teeth secure and not to break or to have any damage during sleep. So we have in the market, some of them are already made. You just buy them, and with the warm, sometimes you have to put them in warm water and then put in the mouth, and then we get the shape of your dents, of your tooth. But the best ones are those ones that the dentist can make specifically for yourself. Some physiotherapists that work daily with these patients say that sometimes patients complain that using these oral appliances make it worse. So we need to see what's going on, because proprioception can be affected, and patients having this thing in the mouth could go for more stretching, for more strengthening and gritting of the teeth. So the other P stands for psychology or PEEP talk. These are behavior strategies. So if patients with sleep bruxism are very anxious and have a huge chance of having mood disorders, we need help from psychologists. The other P stands for pills. Central acting drugs. So sometimes a physician together will also help these patients. The professional, the team collaboration, the interdisciplinary work, transdisciplinary work is a must for the patients with sleep bruxism. And us. We deal very well with these pain issues and with the education of the patients, because we see patients a lot of times during a week, during a month. So, what are the objectives of this non-pharmacological treatment? Well, we have to manage the pain, to reduce the muscle activity, to rehabilitate the function of temporomandibular joint, to normalize the range of motion, the positioning of the joints, to relieve the mechanical stress, to normalize proprioception and muscle balance, to improve oral habits, to prevent muscle compensation, and to avoid the involvement of other regions such as neck and thoracic spines. And how we do that? We do that through therapeutic exercise, relaxation techniques, manual therapies, acupuncture and dry needling, electrotherapy, stretching, low-level laser therapies, and behavior guidance. I know it's too small here. I'm sorry about that. But we performed in this Brazilian consensus, we reviewed the literature and we tried to take some evidence from them from what we had. We still doesn't have much of evidence regarding physiotherapy treatment for sleep bruxism. But what we saw here, you see the strength of the evidence. Here is B, here is C, and here is not recommended. So the evidence B is something that we can work in our practice, like laser, educational and behavioral guidance, transcurrent electroneural stimulation current, PNF associated myofascial release, microcurrents, and relaxation exercise. So we are talking about them just right now. The C stands for something that we have some research in literature, but not with good sample sizes, and maybe we have just 1 or 2 research, so we need to research this more. And this is static and isometric stretching, dry needling at the trigger points. In Brazil, we have a specific formation for dry needling, acupuncture, kinesiotherapy, myofascial release, and what is not recommended because we don't have evidence is the transcutaneous, the tense thing applied to the face muscles, to the neck, okay, to the face we don't have evidence, so we don't recommend that. And kinesiotherapy as a standalone therapy is not recommended. Therapeutic exercise of muscle strengthening are always not recommended. And manipulation and mobilization of the vertebres, we have no evidence to support the recommendation of that. So you can see that the entire paper in the material that I have for you. This is a very nice evidence in literature. This is a comprehensive review of the Dr. Simone Go, and she writes about the importance of having stretching exercises for these patients, because they will improve the range of motion, prevent injury, improve performance, and there are a lot of evidence showing that will also improve the viscoelasticity and therefore the range of motion and the flexibility. So she describes each type of the stretching, passive, active, ballistic, or PNF, and these main characteristics. So this is a paper that it's very interesting for you to have a look. Here are some therapeutic exercises that we can teach the patients to do in our sessions, and then they can take a booklet at home and make it every day. There are also some apps that they can make the exercises and put in the app how many sets they did and everything like that. So we will have a record of everything that they did. There are some evidence on manual therapies. For example, this one, try to see if massage or only the using of this oral appliance, and both of them together, so they had these 3 groups to see what's the effect they would have on EMG and if the symptoms of bruxism would reduce. And what they saw is that both massage and the splint alone, they didn't have any effect on the EMG. But when combined, they didn't have any effect on the EMG, but they reduced the intensity of the symptoms. So combining the therapy is a good thing. This other study also have about the same results. They performed about the same thing, and they had a lot of reducement of the pain when combined therapy was used. So physiotherapy and the dentist together can make better for the patient. In this one, they compared the occlusal splint and the kinesial taping, and they saw that when combined again, they had reduced the pain, increased the range of motion, and they say that one therapy is just efficient as the other one. But the result showed that the therapies alone didn't work so well, but when combined, they worked perfectly. So I think we should think about always having combination of therapies. Here are some manual therapies that we can deliver to the patient. So we have like external ones and internal ones that we go through. The internal ones are very painful, so patients complain a lot, and sometimes they have headache or stomach aches because we are making movements inside the mouth. And I don't know if any of you works inside the mouth of the patients, but this is something that we had a lot of trigger points. Okay, we can feel in our fingers the trigger points of the muscles internally. Also, we can have all the trigger point myofascial and manual therapies from the outside. Another thing that helps a lot, but we need to search for more evidence, is acupuncture or dry needling. Do you know the difference between them? Yes or no? The difference between acupuncture and dry needling? They are different things. Okay? Acupuncture, they both have the same material, so you have a needle, but the acupuncture, you might treat the sleep bruxism by putting the needles in your knee, for example, because the meridian that you need to treat is there. And the dry needling, so you have the philosophy of the traditional Chinese medicine behind that. So you can treat not only locally, but you can treat systemically. In the dry needling, you go with the needle exactly in the trigger point, so you will release it. So you have no philosophy behind that. We also have some research combining here. You see the dry needle and the TENS, okay? I have good results with this in my daily practice. The patients, they say that it works, it's better than when it's without the electrotherapy. But this is really, really annoying. It hurts a little when you use it. So not every patient can stand to be like half an hour or 45 minutes receiving this. There are some new devices coming on. I say new devices, but this one is from 2013. But the research is old, but the devices are, I think, about 8 years, 5 years in the market. So these are TENS units that patients can apply. So this is called Grind Care. You might note that you have a look at it later. So Grind Care is an electrostimulation that will help. We also have some wireless devices that are coming into the market. And some of them, like this one here, it would detect the movement of the muscles before the masticatory movement happens itself, and then it will release slightly tension to relieve the muscles in order not to have the rhythm masticatory thing. But this is a new research. We don't know the mechanisms exactly of what's going on here. So it's something that I think is for later. We also have these laser things in specific points that might help. In Brazil, dentists use that also a lot, but physiotherapists also do. And we also need to go through with the patient into these behavioral and changing habits, mainly for these parafunctional habits that we spoke about. So patient education is a must. We need to have maybe relaxation, hypnosis, go through the sleep hygiene rules, and cognitive behavior therapy is not only for insomnia. There are specific ones for insomnia that we call CBTI. I stands for insomnia. But in sleep, you will always see the CBT thing. So we might have CBTB for bruxism, CBTS for sleep as a whole, and goes like that. And there is this app, Brux app, that we can see if the patient is having any trouble. It is a paid one, and the patient would wear those stickers, and we would monitor if the treatment is going on well or not. Well, let's go through a clinical case. It's not my case. I'm going to present you the case of the Canadian group. So I invited Jacqueline Yam to write this for the book. And she spoke about a patient that she had that was a female, 29 years old, with a long history of orofacial pain. And she had some diseases and didn't present any sleep disorders. In 2018, she had the dental diagnosis of sleep bruxism, and she received the occlusal splint to prevent it and to reduce the damage. Then, 1 year later, she had recurrent acute episodes of severe orofacial pain. It was like 8 in 10. So she was sent to Jacqueline for physiotherapy. They started together to perform some exercises and manual therapy, aiming the improvement of the muscle and joint pain. But it was only with exercising of other body parts like head, neck, and shoulder that they got the pain reduced. So what got her idea at that time was this severe orofacial pain. And this is a drawing of the patient. So the patient drew pain sites, what she was feeling the most. And the Jacqueline performed postural assessment and saw chest rectification, anteriorization of the head, and things like that. The patient also complained about tension headache. The symptoms went worsened when she was in stress, and also in autumn, she complained that every autumn she had more difficulties, but she had some improvement with yoga and with swimming. And she slept in prone and lateral decubitus. She went through a neurological examination of the cranial nerves. Everything was okay. She had a weaker tongue resistance on the right side compared to the left side. She was right side. The right side of her was dominated by pain and muscle spasms, both with intermittent occurrence. She measured the mouth opening, and there was a decrease in the extension and left lateral flexion of the neck spine, with a report of pain at the end of this range of motion. So they needed to, she had an increased neck flexion and the scapular position was okay. But they saw other postural things was going on with her. And then they had the functional tests and the arthrokinematic evaluation of her. And they started treatment once a week for 1 hour, with the dry needling sessions for 1 hour and a half. So this 1 hour was for education, and all sessions included postural education, education about stress, pain, and exercise. They also had a combination of manual therapy and myofascial release. And the patient said that myofascial release was what helped relieving the pain and increasing the mandibular range of motion. So this is a set of exercises that is printed in the book. So they went through each of these exercises in the PT sessions, and then the patient was able to learn how to perform this exercise by herself at home. So they did assisted rotation, isometric neck flexion, resisted head push back, isometric neck side bending, anterior wall side with this myofascial roll, wall side, so she stood in the wall and tried that to hold that for a little bit, resisted mouth opening, and lateral deviation of the mouth also resisted. So they performed about 10 seconds or 1 to 5 times, 1 to 5 minutes each of these exercises. And they also have some things specifically for the mouth and the tongue, like tongue protrusion, tongue stretch, lateralization straightening, isometric diagonal jaw, mouth controlled opening in front of the mirror. This is something very nice to perform with the patients. And we also need to show the patients how they can release the soft tissues by themselves at home if they feel something. So in 3 years of treatment, of having also intraoral manual therapy, bilateral temporomandibular joint, and for sleep bruxism and for the TMG, the patient learned which exercise she needed to maintain, how to change stress, and how to manage posture. So this is to tell you that we don't keep the patient, of course, for us forever. We try to teach the patient the things that they need to do, and they will at first stay with us for a little longer, and then they will manage it because they learned, and they will come back only when they really, really need. So it's our effort to teach to the patients how to manage, to understand and manage their diseases so they can live better. Okay? And there is a reading material for you about that. We are going to have a 5-minute break now and then start with the narcolepsy lecture. Okay, thank you.
Thank you to Dr. Christina Fens, ma'am, for the insightful session on sleep bruxism. The clear explanation of diagnostic tools and case based learning added immense value, bridging theory in the world real clinical application.
We now move on to the next lecture where we delve into the fascinating and complex world of narcolepsy. Once again, Dr. Franz will help us navigate the core concepts, questionnaires, scales, and non-pharmacological approaches that highlights patient care nuances.
Thank you very much. Thank you all again. You're going to get tired of me this morning because I'm here all the morning. So now we are talking about narcolepsy. This is a disease that is very hard for physiotherapists to treat. But I think that we all together can think proper manners. We all together can think in proper manners to treat these patients. I always think that lots of brain thinking together are better than just one. I have a little bit of experience with the narcolepsy patients because my supervisor in my postdoctoral studies, he is, as I said to you before, he's the head of an ambulatory that we have in Brazil going on every Monday during the afternoon. So we used to see, I'm not there any longer, but I was there for 5 years. So we used to see patients, narcolepsy and hypersomnolence patients every Monday. So we have many cases. But what is the definition of narcolepsy? Just let me get my pointer here again. Okay. Narco means numb, sleepiness, torpor, stupor. And lepsy is a Greek word that comes from crisis. So narcolepsy is a disorder characterized by excessive daytime sleepiness and signs of REM sleep instability. So this is a disorder that REM sleep stage intrudes into the wake process. But the patients are called lazy, depressed, shameless. The society see these patients like they have lack of effort, they are sleepyhead, strange, awkward, antisocial, and all those things. Because society doesn't understand what is this disease. Narcolepsy is a sleep-wake disorder that is, again, characterized by the intrusion of the REM sleep or part of the REM sleep into the wakefulness and the sleep. So we might think that in this disorder, that is a disorder of hypersomnolence, we might think that patients sleep too well or that patients sleeps because it's a disorder of hypersomnolence. But this is not true because in this disorder, we also have the fragmented sleep. Okay? So we have daytime and nighttime clinical manifestations as a result from the alterations in the triggering of REM sleep stage. So all the sleep architecture is messed in this disorder. So imagine that you are a runner and then you have a narcolepsy attack, a cataplexy attack. So imagine how dangerous this is for daily life. And why this happens? Well, we have a decrease in the hypocretin, or also called orexin. We have a decrease of this hormone by loss of these hypocrenetic cells in the lateral hypothalamus. We also know that we have no alteration of these receptors, and these are seen in animal studies. And this hypocretin is very, very important for the maintaining of wakefulness. These hypocretin producing neurons, they are the ones that regulate the sleep-wake cycle, and also they have influence in other brain functions. This hypocretin or orexin production is most active during the wakening period and helps maintain long periods of wakefulness, and also regulates our sleep stage or REM sleep. But the specific mechanisms by which loss of hypocretin results in excessive daytime sleepiness and cataplexy are not yet completely understood. So we have two types of narcolepsy: narcolepsy type 1 and narcolepsy type 2. The narcolepsy type 1 is more well-defined etiopathogenesis, and there is a homogeneous one. So we have cataplexy, that is loss of the muscle tone. We can measure the hypocretin deficiency in the cerebrospinal fluid, and we will have in the objective examinations the sleep latency is going to be less than 8 minutes, and we will have more than 2 sleep onset of REM periods. So I'm going to explain this exam in a few minutes. We have a specific examination for that. Just like the polysomnography, there can be a report that we can have it. So if we have all these three things here, the physician will have the diagnosis of narcolepsy type 1. But this other one is a little bit difficult. The type 2 is kind of heterogeneous disease, and the etiopathogenesis is still unclear. The hypocretin deficiency is different from the first one. It can be higher than 110 or not measured for any reasons. And in the objective examination, we can have a sleep latency less than 8 minutes and more than 2, what we call SROREMs. I have 2 videos here with no sound. Just going to show you. Just watch. She's a dancer teacher, or she's recording something, and then watch how it goes. The loss of the muscle tone doesn't have to happen in the whole body. In some patients, it just happens in the face. So the face only drops. So we can have half of the body, the whole body, or just a part. So when we have this sleep attack, what we are having is the REM sleep stage intruding into the wave sleep. So it's completely annoying for the patients and for the ones who are seeing that happen. The first time I saw that happen, I went insane. I didn't know what to do. And my supervisor just said, wait and watch. And I was like, oh my God, okay. And we just make sure that the patient is safe and secure and will not hurt itself. And that's it. So we have some more videos. The pathological findings of the narcolepsy is a selective loss ranging about 75 to 95% of these hypocretin producing neurons in the lateral hypothalamus. We know by animal models research that we have a partial loss of hypocretin, and the narcolepsy without cataplexy, the NT2, and normal cerebrospinal fluid hypocretin levels. For the type 2 patients, we can have one with normal number of hypocretin neurons and another with a reduction about 33%. The thing is that between type 1 and type 2 narcolepsy patients, we have a gray zone that we call gray zone. That we have many patients in between them, and the physicians don't know how to diagnose that. And we tried to write a paper on that, calling the, how was that name? The 11 tones of gray, but they didn't accept it. I think it was because of the title. Well, we also have an increased number of histaminergic neurons in patients with type 1 and animal models. So we don't know if this could be a compensatory response or if are limitations of the methods. But there is a gene predisposition for the narcolepsy patients. So we have this gene here that is responsible for about 98% of the patients with type 1 and about 0.5% of the patients with the type 2. And in general population, this gene is found between 5 and 38%. So also having these gene factors, we might have some environmental factors here, like some triggering ones, just like vaccination. In 2001, we had a specific brand vaccination for flu that triggered this narcolepsy, mainly in the US and Europe. So we had an increase of patients with narcolepsy type 1 because of that. And then we have many clinical symptoms like excessive daytime sleepiness and the cataplexy. So the epidemiology is that it's a really rare disease. It affects both sex, and it has a bimodal prevalence, like between 15 and 35 years old, and type 2 is more common in adolescents, like when they reach 11, 12 years old. There is this gene predisposition, so having a first degree relative with narcolepsy will increase from 10 to 40 times the chance that you might have it. So usually begins when in adolescence and has another peak around the age of 35. In about 10 to 15% of the patients, the onset might occur before 10 years of age, and it can be presented in the acute and chronic manners. This is the five main features of this clinical manifestation of narcolepsy. So we have cataplexy, that is the loss of the muscle tone. We might have sleep paralysis, sleep fragmentation, and these hypnagogic and hypnopompic hallucinations, all of them leading to excessive daytime sleepiness. And I would say really excessive daytime sleepiness. So this daytime sleepiness is the main symptom and the most debilitating one. There is an instability to stay awake, or patients have some sleep attacks that are also reported as a subjective feeling of sleepiness accompanied by a difficulty maintaining attention. This is present in the morning, and this is resistible. And sorry about here, involuntary naps are present in about 80% of the patients. The naps are usually short, about 15 to 20 minutes. So imagine if I have narcolepsy, I would sleep now for 20 minutes and then wake up not knowing what's going on or where I am, what am I doing here. And these naps, they are a little bit restorative and associated with dream-like experiences. About 60% of the patients present fatigue. The cataplexy, another very important feature, is present in about 60% of the patients, and there is a loss of muscle tone, and there are 1/3 of the patients that report falls. Injuries are hair. There is a loss of reflex. This cataplexy can be both generalized or in local areas of the body, and this triggered by emotional facts, because there is an autonomic symptom that may occur, change in blood pressure and heart rate, sweating, and involuntary urination can be present. There is a preservation of consciousness. There are ocular, motor skills, and breathing. Okay, so the cataplexy is triggered by emotional things that happen. So if someone tells you something makes you very, very happy, you will start laughing, and then you have this cataplexy. Well, there is explanation for that. We are not going to go through all of this, but mainly because the absence of the orexin that reduce GABA activity and will lead to this loss of muscle tonic tonus, muscle tone. This again, no sound is required, but this is a child who presented cataplexy. Yeah, it is a little bit annoying of watching it. And the last one, the friends are recording something, and then one of them has this cataplexy. She starts laughing, and then REM sleep enters. Okay. There may also be present some hallucinations. We call it hypnagogic when they happen at the onset of sleep, and hypnopompic when they happen at the onset of awakening. These hallucinations may be present in about 33 to 80% of the patients and is usually visual, but other types of hallucination are possible, such as auditory and tactile ones. Generally, they might present unpleasant dream content. The dreams are vivid, and patients they know this is not real. I had a patient once, and she told me that she knew when she was in this stage, and she knew she was alive and everything that was going on outside, and she knew that the things that she was seeing were from a product of her mind. So she had to learn how to live with this both reality. Can you imagine how hard this is? How difficult it is for a patient like this? So the sleep paralysis is, we talked about sleep paralysis. I talked about with someone, I think she's sitting over there. Yeah. So sleep paralysis usually occurs upon waking. So you are awake, you know that you are awake, but you just can't move any part of your body. You can talk to anyone. You can't move your tongue, you can't move your lips. So this is an inability to move, to talk, and can last from seconds to minutes. So sleep paralysis is the inability to speak or move any muscle that usually occurs during the sleep-wake transition. And this is a terrifying feeling. Other very important feature that we have is the fragmented sleep. So here we see a normal schedule for sleep, a normal hypnogram. So this black bar is representing the sleep time. And here we have all the hypnogram that we already spoke about. And we see here the REM sleep stages. When we have a narcolepsy patient in this 24-hour hypnogram, we see that we also have sleep during the day, lots of sleep during the morning, you see here, and many REM sleep stage entering during awakening. So you see the patient is awake here, then goes to REM sleep, then goes awake again and goes to REM sleep, and this goes on and on and on. Normally, patients with narcolepsy will have a short sleep latency, so would not have any problems to start sleep during the night, but they have many awakenings that can be both brief or very, very long, because somehow they lose the circadian rhythm cues. And it's worse in the second half of the night, because the second half of the night they should be having REM sleep stage. The diagnosis is made by this multiple latency sleep test. So this is a test that we perform during the day, and it's as per recommendations from the American Academy of Sleep Medicine. The patient should have a full night polysomnography the night before, and then the patient stays awake all day at a sleep lab. I can tell you that I had the worst experience being a volunteer for this examination, because we stayed all day in a bedroom in a very cozy environment. The air conditioner was good to go to sleep. We had a dim light, and I had to sit there and wait for sleep. And every time sleep was coming, I was falling asleep and someone would wake me up. So this was something I wanted badly to go to sleep, but I couldn't. So this is the examination. So we have in this examination 5 possibilities of 20 minutes of having a nap in every 2 hours. So this is something that lasts all day. And the measure that are the outcomes from these tests is the sleep latency, or how many minutes I took to nap from the moment that I could, from the moment that I really had a nap. And of course, I had all these electrodes from the polysomnography in my brain. Also, the other thing that they measured was the sleep onset REM periods, how long it takes for the patient to enter the REM sleep state, okay? So the result is like this here. We have like a MLST result sheet we have the hypnogram and the summary. We have the lights off. So here are the opportunities: the first nap opportunity, the second one, the third. And we have the sleep onset, the time that I was in bed, the total sleep time, the sleep latency, and the REM sleep latency. And then we have here the result. So the mean sleep latency of this patient was 2 minutes. So it took 2 minutes on average for the patient to sleep. And the REM sleep latency, so the patient had 3 episodes, okay, here. So we have a graph and things like that. So this hypnogram shows these 5 periods in which the patient was allowed to sleep, and the patient slept in 3 of them. So if we have 2 or more of these REM sleep going on here, the chance that this patient with the other clinical features having type 1 narcolepsy is huge. So this patient had. And the mean latency, you see, the latency here was 2 minutes. The mean latency has to be less than 8 minutes. So this suggests that this patient has hypersomnolence and reinforce the narcolepsy diagnosis. So it's a very, very important objective investigation that we have for narcolepsy patients. The other one that I told you that we are going to talk about is the maintenance of wakefulness test. That is the opposite of this one that we just talked. So this is also made during daytime, seated. The patient is seated. We need the full night polysomnography on the night before, and the patient stays again all day at the lab. It's given 4 tests of 40 minutes and an interval between them, and in every 2 hours, the patient is told not to fall asleep. It measures the sleep latency, again, how many minutes the patient had the sleep. So here we have these 4 opportunities to nap, and this patient here is a normal one. He presented no SORAM, no intrusion of REM sleep, and had a mean latency of sleep of 38.5 minutes. And here, an abnormal one, indicative of hypersomnolence or hypersomnia. In these 4 chances that the subject had to nap, it took less than 22 minutes, and here again 22 minutes, and no REM sleep state. So this is again not because of here, but because of this sleep latency, and this is indicative of hypersomnia, but in this case not of narcolepsy. So this is how you see that is result for this test. the patient goes immediately from wake to REM sleep, then goes to stage N1, then stays the rest of the time of this, you see here, 25 minutes, 40 minutes, he stays in REM sleep stage. Other manner that is quite important to diagnose narcolepsy type 1 patients is having the genes checked. And they do that by cerebral spinal fluid examinations. So they are very reduced or cannot be detectable in 95% of patients with narcolepsy. In patients without cataplexy, these levels are usually normal, and these normal levels are found in patients with familiar or secondary narcolepsy or in patients who are negative for the gene. So these are very expensive studies, but we have conducted some in our center in Brazil. We don't have much to talk about non-pharmacological treatments, but as you see, I think it's a must if we talk about self-care and behavior therapy. So if you have a patient like that, go through sleep hygiene with him. Other very important things that we do is ask the patients to have scheduled naps. So sometimes the physicians write a letter to the employees saying that that patient has a narcolepsy disorder and needs, in each 2 hours, it needs 20 or 30 minutes of sleep. If it's possible, this is a treatment for this sleep. They should have maintenance of regular sleep schedules, and there are some studies going on with supportive groups and psychotherapy. Regular physical activity is a must for all these patients in the same time to become a routine. They need to be very careful with the use of stimulants and need to have a balanced diet because they have a huge risk for getting overweight and obese. Okay, so if you remember that having fragmented sleep is correlated with the hormone levels of ghrelin and leptin, this is why these patients can get really, really obese. Okay, they also have 40 times more chances of presenting pain and chronic pain than normal healthy persons. The treatment for this narcolepsy is pharmacological. Okay, there is I don't think it should one day have a non-pharmacological treatment that will be as a standalone therapy. The treatment is pharmacological. And to my I was astonished when I saw this article from the group from Ireland, from Haggy, Dr. Haggy Tadro, from the group from Ireland. They published it in the Journal of Sleep Research, which made me very, very happy. In the middle of 2023, they published physiotherapists, some knowledges about physiotherapy, some perspectives on physiotherapies for people with narcolepsy. So I was very, very happy to see that. This is for sure the first paper published in physiotherapy for narcolepsy saying exactly these things here. Okay, so I think things are starting for us in a manner, and as we say in Brazil, if we see that and you like it, go to surf the wave. Okay, put yourself in a proper condition. Prepare yourself with evidence, and with people that know what they are doing and go to surf in that wave. That's it that I had for narcolepsy, this very exquisite disorder. And we are going to go to lunch for now, and we are back at 11:45. Okay? I'll be happy to take any questions. Okay.
Thank you, Dr. Christina, ma'am, for unfolding the layers of narcolepsy in such a comprehensive and clinically applicable manner. Your engaging approach provided clarity to a subject that is frequently characterized by diagnostic complexity.
Now we will take a short break to refresh and recharge ourselves. Please join us for a tea at the Nehru Guest House. We will begin with a deeper look into circadian rhythm sleep disorders in our next lecture by 11:30. Welcome back, everyone. Up next, we have a lecture where Dr. Christina Franz Mann will discuss circadian rhythm sleep disorders. This session will not only cover the physiological concepts but also assessment tools, non pharmacological interventions, and clinical cases to deepen our understanding.
Thank you. Welcome back. Well, this is our last lecture. We are coming to an end, and we are talking about something now that a lot of people approached me to ask. That is the circadian rhythm sleep wake disorders. But before we enter that, we need to understand, before we understand the disorders, we need to understand what is a normal, a healthy rhythm. So the circadian rhythm, get my pointer here again. The circadian rhythm is a 24-hour cycle of physical, mental, and behavioral changes that our body goes through. It's also known as our body internal clock. This started with some studies, I think back in 60s, 70s, about a plant who has an endogenous cycle. So the rhythm of these leaves here varied between 10 and 11 p.m., even when we were put in only a dark room. And this thing happened. So researchers started to see that was something else going on beyond the light and dark cycle. So circadian, the word circa means around days. So circadian, around days. What we have is a very, very strong photic information that comes through our eyes and signal to a multiple neuron circuits to the pineal gland. So this information comes here and signals to the pineal gland that will then release the melatonin. This stimulation of the pineal gland during the night, during the dark phase, will release the melatonin, that is one of the very important hormones of sleep. But again, this is not a hypnotic hormone. It's a hormone for circadian. So this melatonin goes into the circulation with broadcast a hormonal message in our entire body for darkness. The specific receptors for this melatonin hormone detect the circulating melatonin and complete this feedback loop from the pineal gland to the central nervous system. Oh, I forgot I did those things. We have a master clock that is a central clock. It's, of course, a metaphor that we have in our brains, but this master clock will regulate the melatonin secretion and also will regulate the core body temperature. So we see here in a 20-hour clock, what we see here is that when we have this increase in melatonin is about the dark phase is starting, so this melatonin increases and pick up in the middle of the night, you see here, and the body core temperature is completely the opposite. It goes down to a nadir, like we call, during the phase that melatonin peaks its highest levels. And then this melatonin starts to decrease while core body temperature starts to increase. And these are two features that are very, very important for making the sleep propensity, for making us sleep. So timing is another thing that is very, very important. We have here, I got this picture just to show you, because I need this to be very clear to you all, that besides the very important master clock that we have in our brains, this is a metaphor, we also have a lot of what we call peripheral clocks. And yes, our muscles, our skeletal muscles, are also peripheral clocks. So if we say that light is a very important entrainment factor, exercise, food, and temperature are also very important ones. I'm saying that having physical exercise and having a routine for physical exercise is as important as exposing yourself to light, okay? Because of these peripheral clocks that we have in our body. All this information, together with many of genetic ones that I'm not going to go through today here because it's not the focus, will have this circadian transcriptional rhythm, and this will make the rhythm in which we wake and sleep. So this is the very famous two-process model created by the group of Dr. Alexander Boberly. And here, what we see is that first, we have here the time of the day, so 6 a.m., 3 p.m., 10 p.m., and 3 a.m. Here we have what we call the homeostatic sleep drive. This is the sleep pressure. As long as we are awake, the pressure for sleep increases, okay? So if I wake up at 6 a.m. in the morning, I'm okay. And then as long as the day takes on, I'm going to feel more and more tired because of many reasons, but one of the reasons is the adenosine hormone that we spoke, I thought, on the second day. And this hormone is increasing during the day until it reaches a time here about 11 p.m. in this model that the subject goes to sleep to clear these products in the brain. Okay? The circadian drive is the opposite and is very dependent of our internal body clocks, the master one and all the peripheral ones that we have in our body. The circadian drive will also have the influence of the light and dark cycle, and these will also increase and have a slight decrease during the afternoon, starting increasing again until both process, you see the homeostatic and the circadian one, are combined with lowest temperature of our body, so we enter into what we call a behavior here, which is sleep. So this is the famous two-process model, and it's very important for us to understand it. I always forget that I put the animation things. So again, here it's the same that I showed before, just to show you that we have a measure that can be drawn in the blood and go to analysis, that is the LMO, dim light melatonin onset. So this is an objective measure. It has its rhythm, so it's quite hard to use that in research, but it's possible, and there are some guidelines for that for those ones who wanted to do research with that. So we have this dim light melatonin response curve that is possible to be traced, and we also have the CBT minimum, the nadir of the temperature that happens during the first time of the night. Dr. Zubia already spoke about being an early bird, which I am in Brazil, not here, and being a night owl, and about this chronotype that we can call one or another. But remember that we spoke, I guess, on the second day also, how important it is to have a routine and to make everything properly at the same time, even on weekends. Okay, so it's no good if I have a routine during the weekdays, and then on weekend I sleep until 3 in the afternoon and I go to sleep at 2 o'clock in the morning. So our body needs the routine to function properly, so it will understand what time hormone have to be produced, what time this hormone that produced has to be released, and things like that. So this information that comes outside from our environment is very important from the inside of our body. Okay, now that we know what are the circadian rhythms, how do we measure them before we enter into the disorders? We measure the circadian rhythms mainly by an objective examination that we call actigraphy. We have many actigraphs in the market. Here are only a few examples. I'm not using actigraphy on my daily practice just because I couldn't buy one until now. Maybe I will next year. But I used this for a few years in my PhD research. And we have many types of actigraphs on the market, ones that will measure only movement, and the ones that will also measure the light exposition and the temperature of the skin. So what are the variables that actigraphy measures? It measures the total sleep time or sleep duration. It measures sleep onset latency. It measures sleep efficiency, and measures the wake after sleep onset. So all of these variables, we have them in the report of the actigraphy. This is an actogram, how the thing is written. So this actogram is created when an activity is charted for 24 hours in a single strip chart. So what we have here is noon, midnight, and noon. And here we have the sleep period. These lines represent movement. So actigraphy will it will write down the movement of our body. And when we rest, it will infer sleep. Okay? So here we see that this subject is very active because it's moving, it's making movements. And we use the actigraph just like a watch. Normally on the left hand, when you write with the right hand, you use in the opposite. But when you write with the left hand, we use in the opposite. In children, because they will take it off, we use on the ankle. Okay? And sometimes we have some actigraphs that can be used as an thoracic belt. There are some actigraphs going on that we can use like fingertips. So here we see that this subject was very active and then slept. We see some little movements during the night and then he wakes up and goes to movement again. So first question that I have for you is, does actigraphy measures sleep? Speak louder, please. Yes, it gives all the sleep variables, but does it measure sleep? No. Okay, it doesn't measure sleep. It infers sleep by movement and rest. So we think that this subject was here sleeping, but it could be in a very quiet position without moving and completely awake. So the only measure that we have for sleep is when we have the electrodes placed on the scalp, and then we can see the brain waves. And reading the brain waves, we can see sleep. So actigraphy is very used in research because it's easy and it's feasible and it's very cheaper compared to polysomnography. But again, it infers sleep. So this is from my PhD, and what you see here is the control group and the insomnia group. This is good because you're starting to learn a little bit of Portuguese also, controle and insomnia. And what we have here in these green bars, we have the sleep time. These pink ones here, you see, is the time that the subject takes the wrist off for bath, for swimming. The actigraphs many of them are waterproof, but we are afraid of what the volunteers can do. So we ask them to take it out while in the water or having water contact and put them on. So you see here we have a blue marker, and we ask them to do the actigraph together with the sleep diary that they are feeling all the time. So they will mark on the sleep diary the time that we take it off, and then mark again the time that we put it on. It will help when we read the exam. So what we see here, we see a routine. Does this patient, each line of this is 1 day, one completely day, okay? So here I have 1, 2, 3, 4, 5, 6, 7, 8, 9 complete days and nights, okay? Does this subject has routine? about the same time of going to bed and about the same time of waking up? Yes, okay? It goes to bed about the same time. Here we have the time. I know it's too small. Here is the going to bed time, and here is the waking up time. If we compare this with this insomnia patient that I have, what we can see is that nap here during the day. One day go to sleep at this time and the other one earlier than later. So we don't see a routine here. And also what we see is that sleep is very fragmented here. So we have lots of movements, a huge movement here. And we cannot see this right here, but while we are reading the actograms and the result sheets, we can see the amplitude of the movement. And there is a certain amount that is considerable for movement. So if we see that, we mark as a movement. So these ones are the ones that I read for my PhD. But I found that this particular patient here had something very, very interesting. In Brazil, we are used to take baths every day, sometimes twice a day because it's hot. It's a hot country. And you see that this patient didn't take it off. So she was not having bath every day. Yeah. So I talked, what's going on? Something is going on. Do you need any help or anything? And she was having bath with the actigraph, okay, in this case. So this is a measure that we can, the polysomnography will take just one night. We will have the picture of just one night. In actigraphy, we can have a picture of 1 month, of 1 year. There are some studies that have 5 years of subjects having this actograph. So you really have a pattern in a long time. This is really interesting. Here you see a 78-year-old female, and what you see here is that in this actogram, that is this figure of these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 15-day actigraphy. What we see is a consistent time of sleeping and going to bed. So we look for the rest intervals here, start time and ending time. We see that this is this patient here had a routine. But this one, you see how different those things are? This one is like that last one that I showed you. So each day is go to sleep in a time and wakes up in another time. So we see that this one doesn't have a routine. So the first thing we have to try to understand is why. What's going on that this subject does not have a routine? Is it a behavioral thing, or is it a disorder that needs another kind of treatment? Other thing that is very, very important is the actigraphy must be taken at least for 10 to 14 days. But you should have your patients performing actigraphy during the weekdays and the weekend, so you can see if there is any change. Sometimes we have some research or some people that ask patients to use only for 3 days. That doesn't give you much information, 3 days, because the routine, the complete routine, can be one during the weekdays because of professional issues and completely different in the weekends. So take at least a minimum of 10 days to evaluate your patients. In research, we usually say 14 days. So this is another kind, and as you see, the black lines are the movements. These blue squares here, we have sleep, And in this one, you see the yellow lines. The yellow means the light that the device is getting. So it has also an amount of how much light this gets. This is very interesting for some types of research. We have a print report, just like in PSG, with all the variables that we can read. And this I brought to you because this was the result of my 6-year PhD. 6 year to this one here. Like, you are all researchers, so you know what I'm speaking about. And here we have, I'm not going to speak about the project itself, but just for you to see that I had 4 groups of postmenopausal women with we studied, this is the control group, so you can see a routine. This is the chronic musculoskeletal pain group. You see it kind slightly different from this one here. And also here we have the insomnia group. So the picture looks like a lot like this one here. And here we have the group with both comorbidities, both with insomnia and chronic musculoskeletal pain. So we compared these actigraphy data in the examination. Okay, now that you know what is a circadian rhythm and how we measure them, these are some of the evaluations that we can have. We can have many others like cortisol curve and other biomarkers, okay? Let's talk a little bit about the disorders. So the circadian rhythm disorders, I usually say, is when one of these athletes misses the perfect timing. So you see, these ones here, they missed. So this would be a circadian disorder. These are caused by alterations in the circadian timekeeping system, its entrainment mechanisms, or a misalignment of the endogenous circadian rhythm with the external environment. So you all know I am suffering right now the effects of a circadian disorder, because for me it's exactly 3:42 in the morning, so I should be entering my second REM sleep stage. My brain for sure is trying to make some slow wave sleeps, and I have to be here with all these lights coming to my eyes, informing my brain that, Chris, you are in India, so this is daytime, it's midday, you are having lunch just right now. So the hardest thing that I find here is not to be awake, it's to eat when I get up. Because when I get up in the morning, I speak to my husband and to my son, and they are going to bed. And my son says, "Oh, mommy, good night." I say, "Good morning." And I have to eat, and I can't. I just keep chewing, and I can't eat because I have no desire to eat at all. So this is the thing that I find most trouble. But back to here. The circadian disorders are when we have normal sleep, quantity and quality, but with an undesirable time. So this timing means a lot. It can happen because of change in light and dark cycle in relation to my internal clock. So I can have an internal clock disorder. It can happens regarding the environment, just like me right now, and I can have a dysfunction in this whole clock mechanism. So one of the dysfunctions might be, for example, lack of melatonin, okay? Or any vitamins that will precede melatonin, for example. We have, as all the sleep disorders, we have a criteria from the International Classification of Sleep Disorders. And these 3 items must be met. So we have a chronic or recurrent pattern of sleep-wake disruption due to an alteration of the endogenous circadian time system. Or we need to have a circadian disruption that will lead to insomnia, excessive daytime sleepiness, or both. I am having both, of course. So when it's time to sleep here, you all go to sleep, and I go like, oh my God, I need to sleep. I have a course tomorrow. I want to go to the busiest market I went in my whole life, and I had all my concept of chaos defined again yesterday, and I can't sleep because it's afternoon for me. I'm not used to sleep during the afternoon. And so I have insomnia symptoms. And during the morning, I'm so sleepless. So both can occur. And the sleep and awake disturbance cause an impair during the day. So it causes headache, it causes an influence on the job I am performing, it influences my relationships. So it needs to have a functional impairment, okay, to be a circadian disorder. So it's what I told you, normal sleep, but at an undesirable time. We have some change in the light-dark cycle in relation to this internal clock. These changes are related to the 24. I think I had this already. I'm sorry. The circadian disorders can be both from intrinsic generated by endogenous mechanisms and extrinsic. So we are going to go through both of them right now. The intrinsic ones, we have all these 4 disorders here. They are generated inside. And the extrinsic ones, they will depend of the environment. So shift work disorder and the jet lag. Let's go first at these intrinsic ones. What we see here is a typical sleep phase. So here we have the clock from 4 o'clock in the afternoon until 4 o'clock the next day. And here in this gray bar, we see the sleep time from midnight until 8 in the morning for this subject here, for example. When we have an advanced phase, the subject should be sleeping here, okay? But it has an advanced phase. It comes prior to sleep time. So instead of going to sleep midnight, this person needs, you remember the homeostatic process and the circadian process. When they meet, for this person, this happens, and the core body temperature is at its lowest. Melatonin is shifted also. So all these happen in advanced phase. Okay? We have the delayed phase. So this one here should be sleeping at midnight, but goes to sleep at 4 o'clock in the morning. And should awake, for example, at 8 in the morning, but it wakes up at midday. So I'm quite sure you are remembering friends and sons, daughters, and people that you know that might like to go until midday sleeping. There are other one called irregular sleep-wake pattern. As you see, all the time we have these black squares here. The subject is sleeping. So doesn't have any routine. It can sleep at any time. We just talked about a patient just before this lecture that have irregular sleep wake up pattern. And finally, these three last bar here represent a non-24-hour sleep pattern. That means that this is in free running. Each day it delays a little bit more. So it's like saying that the day for these ones here doesn't have 24 hours, but have 24.5 hours today, 25 hours tomorrow, 26 hours, and then the next day, and next week the day might have 27, 30 hours. So it's delaying each day a little bit more. Okay, so how do we treat and how do we see each one of them? Delayed sleep-wake phase disorder. So here we have the normal sleep, and this sleep is delayed. It's a significant delay in phase of sleep-wake cycle in relation to desired or required sleep time and wake-up time. Symptoms must be present to be considered chronic at least for 3 months. And sleeping ad libitum, that means as the subject wants, leads to improvement in sleep quality and sleep duration and maintain a delayed phase pattern. And of course, not explained for other disease. So it's very, very common in adolescents. Okay, I have a 14-year-old boy, and at the weekends, during the weekdays, he has routine because of school. But during the weekend, if I let, he will sleep at 2 in the morning and wakes up at 1 in the afternoon. So I have to, everyone who has an adolescent at home knows this. So we need to wake them up and set the proper time. This is the hardest thing to do with them. So it's kind of a normal thing for this age phase, and we were all like that when we were adolescents, okay? And it changes a little bit again when we are adult, and it's going to change again when we are elderly ones. We are just going to go through that. It's more common in adolescents. The prevalence is about 7 to 16%, and there is an estimation that it occurs in about 10% of patients presenting to sleep clinics. There is no gender differences and the positive family history for about 40%. We don't know exactly the causes, but mechanisms can include behavioral factors, psychological ones, genetic involvement, and some alterations in the homeostatic regulation of sleep. The behavioral preferences, they like late evening homework, TV, internet things. They use caffeine to combat sleepiness during the day. They have undesired bedtime and rise time, abnormal relation to his sleep homeostasis, and the ambient has a lot of artificial light during the night, and they have a delayed exposure to bright light in the morning. So this is something that is very, very common in these younger people. The psychological change that we are having are the alterations, of course, in the system, the circadian system, persistent delay despite this sleep-wake time enforcement, hypersensitivity to bright light melatonin suppression, reduced sensitivity to photic entrainment, and prolonged free running period length. We may also have some genetic polymorphisms on the clock gene, per3 gene, and altered homeostatic regulation in these patients. Usually, if we have the sleep diary together with the actigraphy, we see that sleep onset is sometime between 1 and 6 in the morning, and the sleep ends between 10 and 3 o'clock in the afternoon. In the weeks, this is my son. Weekdays, no change. Weekends, this delayed pattern manifests. So sometimes it's difficult to see in daily routine. And my friends that work daily with actigraphy, they like to ask their patients to have the actigraphy examination during holidays, because then they are free to sleep and wake and see the real pattern. In polysomnography, the evidence that we have for this delayed sleep-wake phase disorder is that they have, when in habitual time, they have normal sleep, but when they are in control time, like in social time, in weekdays, okay, they have increased sleep latency and decreased sleep duration because they are sleep deprived somehow. The temperature, the core body temperature has a delayed nadir, and the same stands for the melatonin secretion. And I'm sure you've gone through the Horn and Osterberg questionnaire with Professor Zubia. They have a tendency to be the evening type person. The actogram of this disorder will look like this. Here is 6 a.m. and here is midnight. So here is something about 4:30 in the morning. So we see that this patient sleeps 4, 5, even almost 6 in the morning. See how short was this sleep here. So very, very restrict, okay? And trying to compensate in the other days. Look at this day here. Went to sleep about 3 o'clock in the morning, slept until the next day about 2 o'clock in the afternoon. See? So if we have a long time of this actigraphy going on, each line is a day. So here we have more than 60 days. We see that we have these alterations here, okay? So it is how it will look like in the actogram. And then the patient comes like this, have an evaluation, has a chronotherapy, and then it stabilizes. So our aim is this, to maintain a routine and to teach them how to maintain a routine. Oh, I don't have an actigraphy. Can I do that only with the sleep diary? Yes, we can. So we send the sleep diary at home and ask the patient to fill it out. So having everything together for this delayed sleep-wake phase disorder, the treatment consists of dim light melatonin onset, but we are physiotherapists, we don't work with melatonin because it's a hormone. So how can we treat this patient? We can use cues for the light and dark cycles. So I can instruct this patient to wear dark goggles, okay? The white lenses, just normal dark goggles from 4 o'clock in the afternoon until it reached the night. But we can also wear bright light therapy, and here it's not getting any light and starting to wear it. We need a proper wavelength of the light. We need a proper amount that we call lux. So about 2000 and 2500 lux for 2 or 3 hours starting from 6 a.m. here. Okay, so we can use this bright light therapy. As we can see here, the melatonin is at here we have the normal sleep phase. So melatonin should be here and it's completely delayed in this patient. Same thing happens for this core body temperature. So if I have a delayed phase, what should I do with this patient? I should bring it, I should advance it. So I'm doing it using bright light therapy. Okay, so I'm going to show that to you. This is the glass that I use. So this is one of the things that we have in the market. We also have some light boxes that the patient, it will just look like my computer. The patient can just sit in front of it and turn it on and then have breakfast, read a paper or something. But the thing that I found hard with this box device is that I have to stay in front of it. So I like these glasses that are from Australia, from the group of Professor Danny Eckert, that is very a famous group of research for obstructive and central sleep apnea, but they are also investigating circadian rhythms disorder. So I'm going to show that to you. You all going to handle it. So what we have here inside is a button that we press and a blue light will turn on here. Oh, Chris, but this is not a blue light. I see green. Yeah, we see green, but this is blue, okay? Trust me. And then if I press the button, I have 2 intensities. But our eyes, you see the difference? No, we can't because our eyes can't see the difference of the intensity. So I hang it on like this in the morning here. So those ones who came to my room in the morning to pick me up here saw me like this. So I stay every day here for 1 hour using this bright light. I don't find it very comfortable. When I look to you, okay, but if I have to look down, my eyes goes to this thing, so I find it a little bit annoying. So please hand this carefully and try yourselves. So everyone will have a look at it. Does anyone here makes research on circadian rhythm disorders than you? Anyone else? No? Just her? Okay. So try it on, try the light, see if you can handle it. Now we are talking about the opposite one that is less common, but it's called advanced sleep-wake disorder. In this disorder, the sleep and the wake-up times are usually earlier than society requires. We have an involuntary early morning awakening, so the subject just wakes up in the middle of the night, between 2 to 5 a.m. The prevalence is unknown and there is, as I said, less frequently than the other one. The mechanisms include abnormal phase response light curve, altered exposure to entraining factors like light, physical activity, meals. Okay, meal is another very important training factor. You may also have a familial inheritance, polymorphisms in the PER2 gene or in this other one, and it's very common in preterm infants with low birth at weight. We have that in elderly ones. So this is the other end that we spoke before. So I have many patients that complain, patients with apnea, and they say, oh, I wake up 3 a.m. in the morning and I can't get back to sleep. So this is a difficulty in staying awake until desired time, and they are unable to remain asleep until the desired time for more than 3 months. Of course, there is an impairment in function, and there are also non-age related advanced sleep-wake phase disorders believed to be very, very rare. The prevalence tends to increase as we grow old and is estimated to be about 1%, so kind of rare. How the sleep diary and the actigraphy shows us. The sleep onset is about 6 in the evening to 9 in the evening. The sleep ends in the middle of the night, and as prior in the weekdays we have no known change, and the weekends we have the pattern presenting itself. In the polysomnography we have reduced sleep latency, reduced REM sleep latency, and reduced sleep duration, both showing the sleep restriction and the sleep deprivation that this patient has. The temperature and melatonin will have an advanced lowest temperature, and melatonin will have an advanced secretion also. And in these patients, the Horner-Osterberg questionnaire will show a morning type patient. So here again, we have the normal sleep phase and the normal time of the melatonin and the lowest core body temperature. And in here, we have the lowest core body temperature that is advanced. Sorry, here is advanced. And here we have the melatonin onset that is also advanced. So what we have to do with this patient is this yellow arrow. We have to delay it a little bit. So we use the light here during the night. Okay? So we use here in the night, and we can also in the afternoon, if we have bright light, we can use some dark goggles. So evening bright light therapy is usually about 2500 lux for about 4 hours, starting at 8, or 4,000 lux for 2-3 hours, starting from 8 to 9 hours. So it's a long time to be exposed in these bright light devices. And in case of melatonin, it should have here, in this case, a morning administration. Okay. The irregular sleep-wake pattern, as we see here, no routine is present. We will have an absence of well-defined circadian rhythm sleep-wake cycle, typically more than 3 sleep periods with variable length. The total sleep time, when summed, it should be normal, but the timing that sleep happens is not. It can lead to insomnia or excessive daytime sleepiness, and the prevalence is unknown and associated with some neurological disorders like brain injury or neurodevelopmental disorders or dementia. It's really burdensome on caretakers. The sleep diary and the actigraphy will show an irregular pattern and multiple sleep periods both during the day and during the night. The PSG will also show this irregular pattern, and the sleep may be normal with the age range. The temperature and the melatonin goes completely crazy because of the pattern, and we have no idea if this is a morning type, an evening type, or an indifferent type of person. This is a dysfunctional of central processing that generates this rhythm, and the reduced exposure to bright light and the social shadows also play an important role. For example, institutionalized patients, they can develop this disorder. So the treatment is morning bright light and daytime bright light exposure for children and adults with dementia. Treatment is mainly light and melatonin, okay? So we can also use physical activity as a form to give the cue of timing at the same time every day for these patients. And of course, minimize light and noise exposure during the night. I think this irregular is the most difficult one. Um, to treat and to see in practice. This non-24-hour sleep pattern is the last one from the intrinsic ones, and this is when the circadian pacemaker has no stable phase in relation to the 24-hour light and dark cycle. It's common in blind people, okay, because they don't have the input, the light input, as true. They can see a little bit, they can, it depends on what kind of blindness they have, but they can feel the light, but they cannot have the information coming through the eyes. So is often in blind individuals, and up to 50% of these totally blind subjects that doesn't have this input, the circadian clock free runs with a rhythm that is slightly different from 24 coming to each day a little bit more. So you will also find the name of this disease as free running type or non-entrained type or non-24-hour sleep wake disorder. It is because of a reduced or absent of the entraining effects of the light. They don't have the 40 cues that are insufficient to entrain their circadian rhythms, and the melatonin rhythm may be non-existent or may be very, very delayed. In the sleep diary and actigraphy, we have this unstable pattern and delayed each day a little bit more. In the polysomnographic, we will have also this unstable pattern, and the sleep duration may be normal, but the timing that this sleep occurs is not. Both temperature and melatonin are progressively delayed, and we don't know if they are early birds or night owls. So this is in blue, we see the sleep time, and we see that each day it happens a little bit delayed. So it will look like this or that each day. Okay? In the sleep diary, we will also see the same pattern going on. The treatment is bright light therapy, morning activities, avoiding evening light with blue blocking glasses, and consists of wake promoting or sleep promoting medications to help with the symptoms that this inconsistent timing of sleep happens. Okay? And beta blockers to inhibit morning melatonin secretion. We also have the two final ones that are the extrinsic ones. Well, the jet lag thing, as we talked about. So this is me coming to here, and we have the external environment being temporarily altered in relation to the timing of the endogenous circadian rhythm by quickly traveling across the time zones. The severity of this misalignment depends on how many time zones we've been crossing, and depends if you are going east or west. Okay? So I'm not really worried about it. It is bothersome, but as I get back home, everything will normalize. But I know this, okay? Sometimes patients they just doesn't know. We were discussing prior to this class that I had lots of stomach aches when I got here in your country. That could be because of food, but that could also be because of the jet lag, okay? I think it's both. So we have this misalignment of the biological and the social timing that happens in the jet lag. Some say that it's easier to adjust when you come from India and go to Brazil to visit me. But others say it's harder to adjust when it comes to from Brazil to India. So I'll tell you later which one I found most trouble. This is the first time in my life that I have this jet lag thing. I've been to Africa, I've been to Europe, and I never had it, never suffered from it. So everyone was telling me about the jet lag, and I was going, okay, I never suffered from it. I'm not going to suffer again. So this jet lag causes daytime fatigue and sleepiness, nighttime insomnia, a lot of mood change, difficulty in concentration. Oh my God. Professor Zubia asked me yesterday to write some things, and I was like, "Oh my God, how am I going to write it?" It took me hours to get the thing written because of this difficulty concentration and a general malaise. So these symptoms all they would resolve when we get back home. For eastward travelers should avoid bright light in early morning, but that again depends on where you are and how much time you are away from your home time. So it depends. But what I try to do is increase exposure to bright light in the morning and in the evening. So I try to be with the dark and light cycle. So I have the curtains open. When it's day, I see the light. When it's night, I see that it's dark. This will help me to entrain. Not talking about this. So the treatment is bright light therapy and combined light with some strategies to improve sleep. So a lot of behavior strategies need to be together here. We also need to combine these exercises with light. Outdoor activity, avoiding evening light with blue blocking glasses could be a solution, but there is limited evidence. And following appropriate time schedules of light exposure and evidence before, during, and after flight to reduce this misalignment should reduce jet lag. When I talked to my physician that I was coming to India, she gave me a set of rules to do in Brazil prior to come here. But to be honest with you, it's very hard to make them because I was working until the day I traveled. So I could not adjust the things that she told me in my agenda to come here. Maybe I would have suffered less. and minimizing environment and individual stressors before, during, and after travel could help reducing this fatigue associated with jet lag. And the last of these circadian disorders is the shift work that we call the social jet lag. So this is a desynchronization of the circadian rhythms origination from the disorder between the preference of school schedules and the social or professional obligations that we have because of work, school, childcare, and other responsibilities. So the criteria from the International Classification of Sleep Disorders, there must be a report or insomnia or excessive daytime sleepiness together with a reduction of total sleep time. The symptoms they might be present and associated with the shift work schedule for at least 3 months. We might have a diary or a sleep log, or, if possible, an actigraphy monitoring for at least 14 days, okay? Needs to cover the work days and the free days. And all this disturbance is not explained by any other diseases. So we have different kinds of shift work agendas, and the shift works get worse when we have like an irregular schedule. So we have evening shifts, night shifts, early morning shifts. These are all bad, but they are even okay. Rotating shifts and split shifts, on-call shifts, they are the worst because the body will never know when it's day, when it's night, when it gets to sleep, or and you see, the craziest thing is that these professions are very important. So this is an airplane pilot that has many lives in his hand. This is a physician. This is a physiotherapist that goes into emergency care during the night. So we need and we learn how to be very alert and to be uh, with everything in our minds working during the night shifts. So these are the worst ones. And they all include some kind of sleep deficit, increase of accidents, mistakes, and other adverse health outcomes, just like gastrointestinal, cardiovascular, and psychosocial disorders. And there are increased risk for other sleep disorders. So the shift work is when the worker cannot rest properly after the shift and cannot participate properly in social activities. But yet, we need them for our society to work. So it's kind of very complicated and has many social and cultural aspects. This is a actogram from a shift worker. So in blue, you see the sleep, and in dark here lines, you see the movement. So we see that it has no rhythm at all. Now take a big breath. We are coming to an end, and we have some very quickly clinical cases that I am not resolving them. This time you are resolving them. Okay? So first, we have a 20 years of age with difficulty falling asleep. Can someone please read the case for me? Can you please? Uh, do you think it's better to get the microphone? So everyone will listen.
Woman, 20 years old, complained difficulty initiating sleep, inability to wake up at 8 a.m., problem present for 2 years. During the week, goes to bed at 11 p.m. but only sleeps at 2 or 3 a.m. Alarm wakes up at 6:30 a.m. Tiredness, EDS, weekends wakes up at 11 a.m. rested without complaints. No fragment sleep. Because of the difficulty sleeping, she reports drinking alcoholic beverages or off label medication but feels nauseous in the morning.
Thank you. EDS stands for excessive daytime sleepiness. Okay, I should have written it. So, this is a 20-year-old woman, and this is the sleep diary. So, as we see here, Sunday, Monday, each line we have a day. The arrow pointing down means that she was at bed. The X means the lights out, and this line means sleep. So you have this legenda here. And this is the time that she got out of the bed. So we see how much she thinks that she was sleeping. Okay? So having back again so you can remember, you see that she goes to bed at 11 but only gets to sleep at 2 or 3 a.m. and wakes up very, very early with the alarm clock. Having said all that, what kind of circadian rhythm do you think this could be? Back again? You want me to come back? Okay, let's see that again. She goes to bed at 11 but only sleeps at 2 or 3. Yeah, perfect. Delayed sleep wake phase disorder. Great. What suggest would you tell her? What treatment would you suggest to her? Okay, speak it louder, please. If she can get the microphone. Come on, don't be ashamed. What time you should tell her to wear these fancy goggles?
Bright light therapy.
I don't hear.
Bright light therapy.
Yeah, but at what time?
Morning.
So she has delayed sleep
Morning.
wake phase disorder. What's your aim?
Early sleep. Early
You
sleep.
need to normalize the week. So if the sleep is delayed, you have to, yes, perfect. So you use that in the morning, right? Perfect, thank you. Now we have a 60-year-old man with early morning awakening. This is very common in my practice. Can you read that loud, please? Get the microphone, please.
Irritability in waking up at 4 to 4:30 a.m. without being able to sleep afterwards. Recently retired, woke up very early due to work. He was unsuccessful when trying to adjust to his wife's routine, that is from 11 p.m. to 6:30 a.m. Denies depressive symptoms, denies snoring, stay in bed until morning but feel irritated, naps during the day.
Okay. Now, let's have a look at the sleep diary. So what we see here is
Fixed pattern.
yes, naps during the day, yes. And coming back so you can remember. So he's having difficulty staying awake after 8, and he has been crazy and irritable in waking up at 4 a.m. and cannot sleep again. So, what do you think is going on with this man? Yeah, perfect. Advanced sleep wake phase disorder. What treatment should you suggest to him? Bright light, only bright light. Can we think about something else that could maybe help?
I was about to ask you that in advanced sleep wake phases that are going to sleep earlier, can't we start doing the any type of the moderate to high intensity exercise late in the evening so that it can shift it?
Yes, perfect. I was going to, I was hoping this answer would come true. Exercise is a very important time cue. It will inform our body about the time. So we have to increase the research about exercise for sleep disorders, but also for circadian ones. Okay, there is a group doing it in the US, but they don't have physiotherapists in the group. Okay, they are physiologists and things like that. And this is the thing that we know most because this is us. So we must um, go for research in this area. So exercise, perfect exercise, having a consistent exercise every day at the proper time will help these patients. Okay, it's not so the patients will not have um, the same property that has light. Okay, light is the main one, but exercise is much important too. Okay, so the third one is the sleep older woman that hates routine. Iron, please.
It's a sleepy older woman that needs routine. Female 82 years of age, daughter sought help.
Alzheimer disease.
Alzheimer's disease at an advanced age, living in a long-term care institution. Complaint: EDS, sedentary lifestyle, waking up confused, noisy, and disoriented during the night. Donepezil, 10 mg per night sometimes.
Yeah, she's on these pills to sleep. So, what gets your attention here? Elderly patient, Alzheimer disease, long term institution. So, here we see we don't see, we see the actogram, but we don't see anything in here. We see, I'm not telling what we see. So, remember this one. What do you think is going on with this? What? Perfect. She has irregular sleep. What kind of treatment can be performed?
Exercising routine.
Exercise routine, any kind of routine. Exercise, meal routine, bright light therapy, and socializing, having the curtains open. Every cues must be given to this patient. And also behavioral guidance. Maybe not to the patient, but to, yes, perfect, perfect. That's it. And I think this is the last one. This is a patient with insomnia and EDS. So, someone at the back, please, can you read it for me? Somewhere here in the back.
Female of 30 years old, bilateral enucleation of the eyes due to trauma, adjusted to the condition but has difficulties with routine. Complaints of sleep well in some phases, but in other experience periods of insomnia at night and excessive daytime sleeping during the day for long phases or months, and has noticed a repetition of this pattern since the accident, alternating periods of good sleep and very poor sleep.
So here we have a very specific case due to trauma, and we see the actogram goes on like this. So what we see is that sleep is shifting, delaying each day a little bit more. What kind of sleep disorder would you suspect? Yes, it's easy, isn't it? Non 24-hour sleep. And what kind of treatment? Can it be the same treatment for irregular that we just spoke before? Yeah? Okay. That's it. So here I have for you, so you want to take pictures. Everything grouped together. Okay, this is the last slide. What we have here first is a free learning, so the non 24-hour period. This is a normal individual. So here I have some examples. This is a phase advance that we can have in these disorders, and then again synchronize it. Uh, Here we can have some old age endogenous depression that can have this phase advance, and here the phase delay. So we will have all these coming to seek help from us. So as all the lectures that we have lots of reading material on that too. And with that, I finish this lecture. Okay, thank you. You're very welcome. So first, I want to do something that I do every time I go. I want to take a picture of everyone over there, a selfie. Is it okay? Yeah, okay. Yes, please. Okay, I'm not expert in melatonin, but I'll try. Yes. Yes. Yeah, it depends on the whole thing. And melatonin is not so easy as we see or as everyone talks about, because it also depends on how much do you take. It not depends only on the time that you take, but of how much do you take. So many researchers have been doing um, research on that, trying to look for optimal quantities of melatonin for each kilogram, for example. And for each of the disorders, they will have a proper time, but it will depend on what time do you want. So if you have a delayed disorder, at what time do you want to shift that? So if it's to 9 o'clock, or 10 o'clock or 11 o'clock, the time that you are given the melatonin will also change. So there is no one specific time for everyone. It will depend on what are your aims for that specific patient. So this is something that I find very interesting in sleep science and the sleep physiotherapy, because treatment is completely individualized. Each patient will get something. But in the other side, this makes research very, very hard because it varies a lot. Okay, thank you. The bright light. Yeah, sure. Yes, it will delay your sleep. As soon as you as you are exposed to it. So the best thing to do is when we enter late evening, like when the sun goes down, we should shut off this kind of light and turn on just the yellow ones. You know, dim light, yeah, dim light. So this is something that we can do in our houses, and I do in my house. We only have dim light when it's dark, okay, because it will interfere within the melatonin and therefore with the sleep quality and quantity. Okay, you're welcome.
Actigraphy of measuring sleep onset latency.
How is actually?
Actigraphy measuring sleep onset latency.
Actigraphy is not really measuring sleep. Actigraphy is not able to measure sleep because to measure sleep, we need to have the electrodes placed on the skull to see the brain waves. So we say that actigraphy infers sleep by, and then this is the answer to your question, by the movement of the body. So when the body is movement, I know that that person is active. And when I have no movement or very less movement in amplitude that we can see in the movements of the actogram, we can infer that that subject was sleeping. So we say that actigraphy examination will infer sleep time and waking time. But if I want to know, for example, in which sleep stage the subject of my research is, I need to perform a polysomnography. I'm not going to be able to see that in the actigraphy. So actigraphy in research is usually used for large populations, long follow-up, okay, and just to try to understand a pattern of the circadian rhythm without measuring sleep. Sometimes we will see some research that we will have both actigraphy and polysomnography. Okay?
But actually, as you mentioned, that it usually gives us some information about total sleep time and wake after the sleep onset and sleep onset latency and everything. So, is it really giving us any particular data about humans?
Yes, it does. But again, you cannot say specifically that that was sleep. Okay? But you can say that, for example, that group that you studied with actigraphy took about 40 minutes to go to sleep because you can measure that. Okay, so you will have this as an answer from the actigraph report. Uh, when we there's a lot of studies that compared actigraphy variables with polysomnography variables to see if they match, okay? And they had a pretty good reliability. So that's why we use actigraphy as well, okay? You're welcome. I think I have some of these comparable studies in the material of polysomnography, okay? I think I added two studies specifically about this, so you might want to have a look.
Is the blue light in the glasses different from the blue light that is emitted from our smartphones? Like it is said that
Yes, they are. Yes, they are. They are different in the wavelength, okay? So there are many different wavelengths in one spectrum of light, and if we change these wavelengths, it's just like having another light, okay, and all of them will be a blue light. So you see, our eyes see that, like, at least my eyes see that as green, and this is a blue light, okay. So it depends. There is a great group doing research specifically on that in US is Deborah Skin and Kenneth Wright. And they do this research about the same light but with different wavelengths and the impact on them, trying to find out the best one. Okay? Right. No, they are too if I use in longer times. So, for example, if I wake up 3 in the morning and I want to sleep, but I put the glass on, it's warmed, okay? So I need to know what time should I use it. But I'm not saying for you to use the blue light from your device because it's different, okay? Those are made for treatment, and then there are pros and cons for that. For example, a patient with glaucoma could not use that. Okay, so before we use a device in our practice, we have to check everything to see if we can or cannot use. I don't have the answer to your question. I don't know. I'll find out and let you know later. Good question, but I don't know. If you use both, I don't know. Thank you. Okay? You ready for the selfie? Okay. You just stay there. I'll try to put everyone here. Okay? So just smile. I'll put that in the group. Just one more thing. Do you want to say hello to Brazil? Yeah. Okay, so I'm going to make a quick video. Speak little words in Portuguese. You won't understand anything, but I will translate, and then I'll get back to you all. Okay? So let's go. A gente está aqui em Nova Delhi, acabamos o curso agora, foi um sucesso. A gente conseguiu discutir muita coisa, trazer os fisioterapeutas da Índia. E eu estou honrada com essa participação. E, pessoal, eu quero dizer um oi para todos vocês, fisioterapeutas aí no Brasil. Say hello. And I think I'll be again speaking something for you in this afternoon. Okay? Thank you.
Obrigada, ma'am. A heartfelt thank you to Dr. Franz, ma'am, for this amazing session on circadian rhythm disorders. The blend of theory, diagnostic strategies, and clinical insights was seamlessly delivered and are deeply appreciated.
Now it's time for lunch break. So after lunch, I request everybody to be here back by 2:30 so that we can proceed with the examination followed by the valedictory session. Thank you so much.
मैम मैं 1-2 मिनट की बनाऊंगा।
To have Professor Zahid Ashraf Sir, Dean Faculty of Life Sciences, Jamia Millia Islamia. Professor Zahid Sir has always been supporting us in all our endeavors. To bring this enriching 5 days journey to a thoughtful close, we now invite our esteemed Professor Zubia Wakar ma'am to deliver the valedictory address, reflecting on the key insights and collective learnings as we have gathered over the course of this program.
Good afternoon, everyone. First of all, as she said, it is a most cherished part for you because you will get your certificates now. That is why most of you have come here. And as far as the learning was concerned, I hope you all had a good time. And if you were able to imbibe 30% of what we tried to teach you, I would consider it to be a good beginning, definitely. And this is not the valedictory address that would be given by ma'am. What I'm talking about is just a summary. So excuse me because I will have to read through whatever is given to me to read to. And of course, I didn't write it, someone else wrote it for me because I didn't have the time to sit through and attend to the entire program. So first of all, I would like to say that it of course gives me an immense pleasure to welcome all of you towards this closure ceremony. And before we conclude this exceptional academic journey, it would be definitely be called an exceptional academic journey because this was something where we tried to create new inroads for our profession, which should be considered a remarkable thing because of our GIAN course on non-pharmacological interventions for sleep, which was organized under the aegis of the Global Initiative of Academic Networks, supported by the Ministry of Education, Government of India. This course has been special in more than one ways. For our department, it has been truly monumental. For the very first time, CPRS at Jamia Millia Islamia had hosted a GIAN program. It is a proud moment not just for our faculty, but for physiotherapy as a discipline too. To see this field evolve from periphery of traditional healthcare to a space of thought leadership, innovation, and global collaboration is something truly meaningful. Over these 5 days, we explored one of the most underestimated yet vital elements of human health, which is sleep. And not sleep in its abstract sense, but its structure, its science, its disorders, and its central role in healing and human function. Through the course of 5 days, we have thoroughly understood sleep and its role in health and well-being of an individual. We have stressed again and again on why we need to understand and effectively treat sleep problems and disorders with a larger emphasis on non-pharmacological interventions for the same. We divided the course into a 5 days thing where we tried to touch upon on the first day we talked about the basics, then we talked about the assessment, then slowly we went into the clinical conditions and then non-pharmacological management. We wanted to cover up a lot of more things, but because of the time constraint, we could not call experts from yoga and tai chi, which would have loved to call also. So the first day of the course aimed at building the fundamentals of sleep and underlying physiological processes. So also talked about or rather touched upon the newer advancements and technological processes which have been seen. Along the course of the day, the systems of the human body and consistently having poor sleep health can be unfavorably elaborated on the assertion while speaking on how the current literature on the essentials of sleep includes circadian and homeostatic drives. The second day of the course began with a lecture on understanding the need of assessment of sleep in clinical practice by Dr. Frand, who effectively spoke on the same thought through her experiences and exposure, giving important clinical pearls that were meant to stay with us during our own research and practice. She gave good insights on how a sleep assessment can be used for sleep physiotherapy. The next lecture, as given by me, focused on the subjective assessment of sleep, mainly talking about questionnaires, where you understood about the usage, the applicability, understanding. I hope it was of help to you, and I hope that you are able to use it in your daily practices, because this was the part which was, I think, most usable by all of us. Immediately, right from tomorrow, you can go back to your clinics and start using it. An important purpose of the course was also to develop an understanding that sleep is a behavior with a strong influence of individual differences and practices on the quality, quantity, and timing of the sleep. On the day 3, hence we began with a lecture on the sleep hygiene, and we also spoke about the best efforts on putting forward the existing philosophies on defining sleep health and insufficiencies in each of them. The lecture further imposed the importance of good sleep hygiene and how it may be the first line of defense against the most commonly seen sleep pattern inconsistencies. Moving on, Dr. Christina in the next session introduced the basics of PSG and sleep hypnogram, thus explaining you how on the analysis and interpret the same. Additionally, Dr. Christina Franch on the fourth day also proceeded with lectures on two important topics, basic and apnea, obstructive as well as central apnea. She detailed on the significance of PAP devices as the most important non-pharmacological intervention for such conditions. For the second session, we had a session with Dr. Manjari Tripathi from All India Institute of Medical Sciences, who spoke on Yog Nidra and also conducted a tutorial on the same. On the final day of the GIAN program, we had Dr. Christina, who took over the entire course from the morning, speaking on less understood sleep pathologies like sleep bruxism and narcolepsy, and how to observe and treat them in daily clinical practices. She also took an extensive lecture on circadian rhythm sleep disorders, delving in detail of the hormonal and physiological underplays of the rhythm abnormalities. Further, she introduced the concepts of actigraphy in assessing and as an adjunct to the treatment of such issues. Sleep, as we've come to understand during this course, is not just a biological downtime, it is a period of recalibration, restoration, and integration. It is when the body heals, the mind processes, and the nerve system rest. And most importantly, it is non-negotiable for physical and emotional recovery. In physiotherapy, we often speak of pain, inflammation.
Senior person in the field and coming all the way to this country where despite having all those cultural and all the food related issues initially, she was was able to deliver in such a wonderful way. I'll come back to the science, and then as usual third on the dice is our dynamic director, Professor Zubia, and her again congratulations to her entire team, and I can see few faculties here and other. I'm sure for others she might have assigned some job, that's why she's not here. So, and my dear participants and then other students, I think she has explained almost every point with somnography and all those. But I am glad to see Jamia has taken a big initiative and good initiative in such an important issue of sleep, and which has got entirely different relevance in the modern emerging world. Not only in terms of like adjustment of your erratic working lifestyle, earlier 10 years back, 20 years back, people were never having this idea that your work cycle, your work time will start, work from home will start from 10 o'clock in the night to 2 o'clock in the morning, or from 2 o'clock in the day to 12 o'clock till midnight. So those all sleep studies initially were done keeping in the mind of looking into conventional disturbances, right? If you have this all correlated with cognitive interference, but now this is creating new sorts of challenges for those who are working in the area of sleep or those who are trying to understand sleep. This interference of human-led in erratic lifestyles or compulsive lifestyle, I would say that you're sitting in one side of the globe looking into the problem, addressing the problem on the other side of the globe. Somebody is doing shopping in US and you are working back at the back end middle of the night looking into the total expenses sitting back in India. So these all have made this topic such a relevant, such a new, and then brought so many new challenges. And then lately this all screen, looking up to the screen, and especially blue light has again transformed the whole the dynamics of understanding the sleep, not in terms of conventional interference, what we were looking earlier. Now, even if you're sleeping, your mind is not sleeping. That's another big challenge. You go to the bed having the target like tomorrow morning, I have to do 20 different things. So, keeping these all things in mind, this whole workshop becomes very important. And as I've told in the inaugural address also, that I personally have gone through all those CBT and pharmacological, means that hypnotism based therapy, which slows down your whole cognitive system, and eventually you follow a sleep cycle because of some personal issues. I'm saying that becomes very much important to have a non-pharmacological intervention, and as Professor Zubia has highlighted, they try to use Dr. Christina's skill to the max, using her for every possible thing, and then that was reflected not only with her lecture, but this is amazing book. I think that I kept with my folder, so whenever I'll get chance, I'll get through. So such a huge compilation of all relevant topics, not only sleep, sleep in terms of all clinical, pathological, molecular, and then their correlation with lifestyle, their correlation with other comorbidities and so I think they have done excellent job. I can see from the list and from your active participation would have, I think, a very exciting, stimulating whole week, and I request you all to please follow it up, keep it up. You have been infused with such a new challenge for the career, for the life. So please try to be, each of you, try to be a seed for new sleep related research, sleep related clinical practices. Once again, I congratulate you all for taking this 5 days of intensive learning to a fruitful conclusion, and congratulations to the entire team for arranging, for hosting such a wonderful resource person. We would like her to be a permanent resource person. Let's see how, if we can invite her to be a visiting faculty. You can come over in the summer or winter, whenever you feel like stuff in Brazil, we are you're welcome there. And please take few of our faculties also to train them. So once again, congratulations and thank you.
Thank you so much, sir, for your inspiring words. I request Professor Zubia ma'am to present a token of our deepest appreciation to Professor Zahid Ashraf, sir.
It is now our privilege to invite Professor Kia Sarkar Ma'am, Dean of the Faculty of Dentistry, Jamia Millia Islamia, to address the gathering. We look forward to hearing her valuable insights and words of encouragement as we mark the culmination of this academic journey.
So, very good afternoon to all of you. First of all, thank you for inviting me to this very, I think, very special event on sleep. And congratulations, Dr. Zahid, and under your leadership, Dr. Zubia, for taking up this topic of non-pharmacological interventions on sleep. I think most of us are aware, you guys are all still young, but these things are happening early now because of the lifestyle that we lead. But otherwise, we are quite familiar, I think, that with increasing age, sleep problems, which you really take so much for granted when you're young, and all that really becomes an issue. And the recognition of non-pharmacological things like yoga, meditation, really taking center stage, I think, nowadays. And I believe y'all are like half from internal people are from Jamia, and half of y'all have come from outside for this. But I believe most of y'all are people who are involved in sleep management. No, are they? Okay. Okay. So that's wonderful, because I was just thinking that, there's also a need for increasing the public awareness of how important it is to maybe, do these little things to ensure good sleep hygiene and sleep health. And Dr. Christina, I was seeing on the list, and from what I heard from them, you've had a good busy session here. I can see lots of classes even over the weekends and the holidays. I'm sure everyone has benefited from the perspective that she's bringing to this. And I'm sure it would have been interesting for her too to hear about the yoga interventions and all. I don't know whether that's also a mainstream thing in Brazil for management of sleep, but here getting more and more mainstream. So once again, I hope all of you have found it useful. I'm sure it's been enjoyable. Those who have come to Jamia, hope you've enjoyed your stay and your visit to Jamia over the last 5 days. Congratulations once again to all of you. Thank you.
Thank you, Professor Kia Sarkar ma'am, for your inspiring words and gracious presence. We are truly grateful for your time and thoughtful contribution to today's proceedings. I request Professor Zubia Vakar ma'am to present a token of appreciation to Professor Kia Sarkar ma'am. Thank you so much, ma'am.
We now invite our dignitaries to kindly come forward for the distribution of participation certificates to all our attendees. This token of appreciation acknowledges your commitment to academic excellence and your dedication to continuous professional growth. We request all the participants to kindly sign on the sheet as well after collecting your certificate.
Mr. Kapil Kumar from Dr. Bhimrao Ramji Ambedkar Government Medical College.
Vikas Chandra Kushwaha, Fareen Haider from Lovely Professional University,
Ghufran Jalil. अकॉर्डिंग लिस्ट हमारे पास है. Ghufran Jalil, sir, from Aligarh Muslim University.
Bhavna Verma, UPU MS Itawa. Okay.
Asif Iqbal, UP UMS Safai Etawa.
Monica Swaroop, UPU MS Safai Itawa.
Gaurav Shakia, UP UMS Safai Etawa.
Abhishek Kumar, UPU MS Safai Itawa.
Abhishek Kanojia. Archana Verma, UP UMS Safai Etawa. Mukesh Kumar, SG PG IMS Lucknow.
Aarti Gupta, SGT University Gurugram. Anushri Rai, SGT University Gurugram.
Aditi, SGT University Gurugram.
Atiya Shamshad, Integral University Lucknow.
Kamini Sharma, Jamia Millia Islamia.
Tabassum Fatima, Jamia Millia Islamia.
Muazzam Hussain Khan, sir, Jamia Millia Islamia. Tabassum. Tabassum Fatima. Muazzam Hussain Khan, sir, from Jamia Millia Islamia. Sara Nishat from Jamia Millia Islamia. Ritika Ria from Jamia Millia Islamia. Hamda Furqan from Jamia Millia Islamia.
Pushpa from Jamia Millia Islamia. Priyanka Rani, Jamia Millia Islamia. Tarushi Tanwar, Kasturba Medical College of Mangalore, Karnataka.
Shivam Monga, Dasmesh College of Physiotherapy, Faridkot. Musawwir Mohsin Parsa from Jamia Millia Islamia.
Mohammad Furqan, Jamia Millia Islamia. Haris Iqbal Khan, Jamia Millia Islamia.
Mahima Mai Tripathi, Jamia Millia Islamia.
Anureet Kaur, Jamia Millia Islamia.
Noor Jahan, Jamia Millia Islamia.
Zaini Khan, Jamia Millia Islamia.
Ali Abbas, Jamia Millia Islamia.
Tasmia Siddiqui, Jamia Millia Islamia.
Aziza Nazneen, Jamia Millia Islamia.
Shabnam, Manav Rachna University, Faridabad.
Shahrukh Hamid, Jamia Millia Islamia.
Lubna Zahid, House of Movement and Excellence, New Delhi.
Sana Rahman, Jamia Millia Islamia.
Alaf Shah, St. Stephen's Hospital, New Delhi.
Afsha Parveen, Jamia Hamdard.
Chavi Arora Sehgal Ma'am, Jamia Millia Islamia.
Iram Ma'am, Jamia Millia Islamia.
Bushra Tanveer Ma'am, Jamia Millia Islamia.
Khushi Saxena, Jamia Millia Islamia.
Faisal Javed, Jamia Millia Islamia.
Dipali Biduri, Delhi Pharmaceutical Sciences and Research University.
Mohammad Farhan Alam, Jamia Hamdard.
Aqsa Mujaddadi Ma'am, Jamia Millia Islamia.
Tanveer Bhola, Jamia Hamdard.
Adila Parveen Ma'am, Jamia Millia Islamia.
Gayatri Goyal, Jamia Hamdard.
Ibadur Rahman, Jamia Millia Islamia.
Archita Agarwal, Jamia Hamdard.
Shifa Gauri, Jamia Hamdard.
Palka Mittal, Dipsaru.
Atika Khan, Jamia Hamdard.
Thank you so much all for your participation, and thank you so much to all the dignitaries. Now I request Dr. Christina Franch, ma'am, our esteemed foreign faculty for this course, to address the gathering.
I am not talking too much because, as I told Zubia, I'm definitely getting emotional. So, I just want to tell you that if you came here to learn something about sleep in non-pharmacological approach to sleep, and if you're going back home with more queries than answers, then we are sure we've made our job. So welcome to the sleep world. We need a lot of physiotherapists working on sleep, and I'm very happy to be here. I had a wonderful time. I love your country. You can see by my smiling face, despite the food that I love the taste, I love the smell, but cannot try. And I like to thank Zubia for everything, thank the university for making this happen, and thank to the GIAN program. Thank you all very much.
Thank you so much, Christina ma'am. I request Professor Kia Sarkar ma'am and Professor Zahid Ashraf sir to please felicitate Christina ma'am.
Please give a huge round of applause. Dr. Christina ma'am has provided us with immense knowledge over these past 5 days, and we are extremely grateful to her. Thank you so much to all our dignitaries. It is now time to invite a highly respected and inspiring figure of our center, someone known for his dedicated leadership, approachable nature, and constant support to both students and faculties, Professor Suraj Kumar sir. Sir, we invite you to deliver the vote of thanks.
Good afternoon to all of you, our esteemed guests, respected faculty members, our Dean Professor Jahid Ashraf, and Professor Kia Sarkar, Dean Dentistry, and my dear friends and students. As we draw the curtains of 5-day GIAN course titled Non-Pharmacological Intervention for Sleep, held from April 11th to 15th April and organized by the Center of Physiotherapy and Rehabilitation Sciences, Jamia Millia Islamia, I stand before you with immense gratitude. First and foremost, our deepest appreciation goes to our visionary course coordinator, Professor Jubia Vakar. Your your unwavering commitment and leadership have been the cornerstone of the program success, and we are profoundly grateful to our international faculty, Dr. Christina French, for sharing her invaluable insight and expertise. Your contribution have significantly enriched our understanding of sleep intervention. Professor Jahid Ashraf sir, our Dean Faculty of Life Sciences, have always encourages us for any kind of research and academic activities, and Professor Kia Sarkar is also always encouraging research activity of all Jamia Millia Islamia students as well as faculty members. So our heartiest thanks to our Vice Chancellor, Professor Mazhar Asif sir, and Registrar, Professor Muhammad Mahtab Alam Rizvi, for their steadfast support and encouragement, which has been instrumental in bringing this course to fusion. To the dedicated CPRS organizing team, your meticulous planning and tireless effort have ensured the seamless execution of this program. Your behind the scenes work has not gone. We are truly thankful to all of you. To all the participants, especially came from different places of the country and different states, especially from the Lucknow, Kannauj, Safai, and all places, Chandigarh. So you all are really encouraged and enthusiastic after this program. And while this valedictory session marks the formal conclusion of our course. It is no means to end of our journey. Basically, it's a start your journey from here. Whatever you learn from this 5 days program, you will practice to your own patient, your own society, and your family member also. And whatever you learn from this courses, you have to apply on your all patients who are in your daily routine. And basically your performance is actually, sleep is not basically a single identity. Sleep is associated with almost all the physical dysfunction, all the physiological dysfunction, and all the mental dysfunction. So whatever you have patient, like you have uh, hypothyroidism, urinary dysfunction, cardiac problem, respiratory problem, all have related to sleep disturbances. So whatever you see the patient, you apply that learned part of this 5 days program, and then this program is success almost. So today we have one patient related to the sleep problem. We are here right now, and he came from here. After listening this kind of thing, in Jamia there is a program going on in a sleep problem. So he will discuss with after this program with Dr. Jubia and Dr. Friends, and take some help related to sleep problem. This is also a big advantage of this course right now. So thanks to all of you for this for wonderful program and attending this program. Thank you all.
Thank you so much, sir. As we draw the curtains on today's enlightening sessions, we extend our heartfelt thanks to each and every one of you for being a part of this academic journey. From in-depth theoretical insights to hands-on practical learning, these 5 days have truly been a celebration of knowledge, collaboration, and clinical excellence.
Let today not be an end, but a beginning of deeper exploration, stronger collaborations, and continued commitment to excellence in physiotherapy and rehabilitation sciences.
And now, to mark the formal conclusion of this wonderful event, we request everyone to kindly stand for the national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
We request everyone to join us for high tea at the Nehru Guest House. Thank you so much.
And don't forget to get your coupons with you.